Good afternoon to all our lovely participants attending the live webinar from various parts of the world. Namaste. Warm greetings to each and every one of you attending this webinar from India, from the Middle East, from Germany, and from all parts of the world. Greetings from team DentistChannel.Online. It's a pleasure to have you during this webinar. We hope you all are doing well and you're all set to begin with the webinar. We have with us a very special person, Dr. Ehab Rashed, who is an oral surgeon based in Dubai. He is a diplomate of the International Congress of Oral Implantologists, an expert of DGOI, and also an expert of Dental XP. Thank you for joining us, Dr. Ehab. I request you to kindly start with the scientific presentation.
Thank you very much for inviting me over to present this presentation. I hope everyone is safe and keeping well. I know it's a difficult time of the this COVID-19 and everyone is in nearly lockdown. Things are easing a bit in Dubai now. We can go back to work with precautions, and I hope everyone will stay nice and safe. Today, my topic will be talking about guided bone regeneration, and just to let people understand how to always be successful and predictable at the end of the treatment. I see many colleagues using different techniques, but everyone is reaching the same goal, which is bone growth at the defected area. And also some other colleagues using techniques that it doesn't give them enough amount of bone. And this is because due to some mistakes that generally done in every practice. And I will go through the lecture together with you in a very simple way to make sure that whenever you do a guided bone regeneration, you always achieve success. I will not bore you a lot with the scientific kind of discussions, because everyone can go to textbook and read the things. But just to make it simple, what the meaning of the guided bone regeneration, it means that you need to graft the bone and followed by tissue at the site that doesn't have enough volume of bone to compensate the function and the aesthetic and the have a good prosthetic restoration at the site. So usually we do this when we have a deficient site and we want to grow the bone in a way that we will have a good result aesthetically and functional way, also in kind of a prosthetic way. So this is the indication, that's just a simple indication when we do bone graft. We do bone graft, we need to build the bone around the implant, especially after extraction. And we also, when we do sometimes socket preservation, in some cases we are not allowed to place our implant due to insufficient amount of bone to hold the implant or any other reason. So we have to preserve the socket, so we don't want to have a big collapse. And also filling the defect after extraction of impacted teeth, or if you remove any pathology like a cyst, or if you do an impacted tooth like a premolar, for example, and you remove it, you have to kind of rebuild the bone at the site. And also repairing the bone defect after reopening around the implant. In some cases, we have to regraft the site again and proceed with the bone regeneration. Just to understand how does it work, we need actually always growth factors that comes from our body. Usually it's circulating in the plasma. And then also we have also the osteogenesis cells, which is the stem cells and the osteoblasts. And then we have the scaffolds or the minerals that the site that will help the cells to crawl on it. And then we leave everything together and give it time for healing. And then we achieve what we looking for, which is quite a big amount of bone, as we can see in this lower picture here. Also, when we use bone and substitute, we have to understand what's happening, why we're using this bone, which kind of bone cells do we need. And just to make it simple, we look at these little research. It's showing us that there's usually the bone material either osteoinductive or osteoconductive. And what the difference between these two words, we have to understand exactly. Osteoinductive is the cells that will really introduce the vital bone cells. Usually these cells are vital cells or some kind of cell that will create the natural cells to grow at the site. And the conductive mean like the scaffold or the material that you will place it at the site, and it will help the cells to move around it and crawl around it to reach the site and form the bone at the site. Because we understand if there is a gap, the bone cells cannot just crawl in the space. They need something to lean on, to walk on, and climb. And this is that's why we call them the scaffold or the osteoconductive. And also we have to understand also something, that sometimes when we take the bone from a human, we call it allograft, which is from a bank. And if we use the material that we take from animals, we call it xenograft. And if you use a material that synthesized in the in the lab, we call it alloplastic or synthetic material, like minerals that I will later on talk about. Also, one thing that we have to understand, that we always have to use a membrane, and this membrane is a barrier, because what the membrane is doing, this membrane will support the graft site and will stop the soft tissue to grow at the site. We can use different membranes. You can use either a rigid membrane or a soft membrane, or you can use what we call reinforced membrane. Every membrane is used for a specific condition, because you have to look at the surrounding at the area to understand how do we use the right membrane at the specific site. Also, a study showing us that when we need a long-term success, we need about 2 millimeter always buccal to any implant we place. So if you have any deficient area, if you place an implant and the amount of bone that you can see at the site buccal to the implant is less than 2 millimeter, you would expect some bone resorption after loading and after bone remodeling. So we have to graft that site, we have to make it thicker. And also we understand that the bone always will support the soft tissue. So if the soft tissue receding, this is because there is no bone to hold it or to support it. And we later on understand also a few things, like when we do something like this kind of case, we have to look at the site to see if we can stabilize our implant, if we can get the blood to the site, if we can place a material that will help the tissue to grow, if we really place a vital tissue at the site. And also at the end, at the last image here, you can see that we can also place something to protect the site to achieve our goal. So this is an indication, as I mentioned earlier, but sometimes we need to understand where can we take the bone from, or what kind of bone we should take. We understand that when we take the bone from the patient, this is called the autogenous bone, and this is the gold standard. And we can always take this bone from one of the 3 points, either the symphysis manti, the retromolar area, which is my area of choice, and also the tuberosity, that also sometimes I take bone from that area, because that bone is quite porous and have lots of bone cells at the site. And we can see that the substitute, as I mentioned before, the either allograft, which is from a donor, or a xenograft or synthetic from a kind of beta-tricalcium phosphate or hydroxyapatite. The xenograft, that we use it a lot as a bovine bone, that you can take it from animal like a bio-os or sera bone. Also the allograft that you can always take from a human. We know the maxigraft and the puro-os and the Cinebone, and we have lots of brands. I don't want to specify in a brand, but you have to understand when you buy a material to use, you have to understand what are you buying, and this material can be used in which kind of indication, because not every site is indicated for the same material. And that's why this is something common that everyone usually ask me, all these young dentists ask me, do you like to use autogenous bone? Do you like to use xenograft? Do you like to use synthetic bone? It's not if I like or I don't like. You have to understand what every material is doing and what the indication of this material at the site. If this site is suitable for this material or no, because not every material can be used in every single defect. So this is something is very important. We have to understand it. One thing that I usually use a lot now is the sticky bone. I'm sure all of you hear about it. It's been now in the field for many years, more than 10 years now. I've been using this, and this was discovered or created by Professor Don from Korea. And basically what you do, you get the bone substitute and you mix it together with the growth factors that you take from the patient after centrifuging the blood and taking the plasma with the growth factors, and you place it together. Let's see what the essential factors for success of the graft. we have to understand that we have 4 factors. I call it 4, the +1, and these factors are the essential factors. If you do any bone graft, you have to keep in mind that all these factors, if they are not available at the site, you will not have any bone at the site, and you will lose all what you did. Let's go through this to see what this, the primary wound closure. If we graft a site and placed everything that we can place and put the growth factors and place your autogenous bone, if you don't do the primary wound closure, you will lose all your grafts. So this is a prime thing that you have to use. Always make sure that you close the wound completely and the flap is totally sealed, because if there any kind of exposure, you're going to lose this bone during the healing. The second thing that we have to look at that after, it's the stability of your implant. If you place an implant at the site and you graft the site, you have to make sure that the implant is totally stable, because any minor mobility in the implant or micro motion leads to a failure of the implant site and create an infection, and this area will not have an osseointegration or not have a bone growth at the site. One more thing is the second S, with the stability of the graft. You have to stabilize your graft, make sure that the graft is totally stable. And I will show you later on how to make sure that the graft is stable, because this is something very crucial, because I see many dentists putting just the bone particles or the artificial bone particle at the site. You put it on the top of the implant and then just cover it with a soft membrane. And then if the patient touch the mouth, or if the patient pull the muscles, or the patient talk, or even if you flap the site and just suture it later on, all the bone will be scattered. So you have to make sure that this bone substitute that you put, or bone particle that you put at the site, they're totally stable and they're not moving or shaking from a place to another. The third S is the blood supply. You have to make sure that there's blood coming, because we know that any graft that we do, or any soft tissue or hard tissue grafted, if this graft is not totally supplied with enough amount of blood, you're going to lose the graft, because the blood will bring the oxygen to the cells. The blood will bring also the stem cells to the site to initiate the healing, and also the blood will create the oxygen and the nutrition to the new cells that you already placed. So if you don't have this amount of nutrition and oxygen to the site will start having necrosis, and you're going to lose everything. The last and the most important one also is the space. We understand that in many cases, when we graft the site and place our bone particles, either allograft or xenograft or whatever you use, and then you just suture the site with the flap, what you do, you squeeze the site with your flap, and then you suture it and make sure it's tight, and then by this you crushed all the site with the soft tissue, and the bone cells doesn't have the ability of the strength to move the soft tissue away. They cannot push the tissue to grow at the site. If they have no room to grow, they will not grow. And this is also one of the main reasons that we always don't have bone at the site after we come back, if using what we call it the soft membrane. This is something very, just to demonstrate to you, how do we achieve a primary wound closure. You can see here that I placed my number 1 on the blade, because usually when you do this, you should always use 2 blades, because these blades, once they touch the bone, and when you're doing the first incision, which is the incision that you do to start the flap, which is the crystal incision, as you can see here, this blade is already blunt anymore. It's not effective anymore. So first we do the crystal incision at the site that we want to graft the site, and then after that we have to do what we call it the vertical incision. And if you see the vertical incision, they extend to a wider base, because you need a wider base at the bottom, because this base will bring the blood supply. So I need to widen the base of the flap, and then also this vertical incision must pass through the mucogingival junction. So just making the incision at the keratinized tissue is not enough, because you cannot release the flap enough that way. So you have to extend it beyond the mucogingival junction, and then you get the second blade here, this second blade that I will show you now, and this blade is to do the periosteal incision. If you look at the periosteal incision, you see the incision is wider than the incisal incision. This is something very crucial, very important, that when you do incision to release your flap, you have to extend the incision beyond the vertical incision, and this is how you create mobility and you can retract the flap more to make sure that you're getting a primary wound closure. So after that, we can place our bone, and you can see that you place the bone after you do the releasing incision. So I've noticed that many colleagues place the bone at the site and then try to close the flap, and the flap is not closing. So they bring back, go back to the area and get a blade and start cutting, and then the area get full of blood, and you can create hematoma at the site, and this can interfere with the healing of the site. If you look at different techniques has been used by different colleagues. This is Dr. Peter Amin. He's actually graduate from Egypt, and he's practicing now in the US. You can see that he has a big defect of the top picture here, and just by using a reinforced membrane, and you can see how much bone that he received at the end of the healing. And this is because he implemented the facts that we discussed, which is the 1 and plus 4S, which is a primary closure, stability of the implant, stability of the graft, and also the supply of the blood to the site. And you can see how much bone that he gained at the healing time. And if you look, another kind of technique is used by my colleague, Dr. Ehab Musa, also from Alexandria, and he's working in USA at the moment. You can see that he also uses a different technique, which is the Curi technique. He take a plate here, as you can see, and this plate will act as a space maintainer. And also the plate vital bone cells, so also it will stabilize and it will produce bone cells at the site, and you can see how much bone he received at the end. So different techniques being used, but the end result is equal. So basically it doesn't matter what technique you use, as long as you keep in consideration these 4+1 basics that we discussed at the beginning, and then you will always achieve the same amount of kind of result. This is a case that we will discuss later on in details. You can also see that we also gained a big amount of bone at the site after a big defect, as you can see on the left and the right side of the patient. So whenever we use this kind of techniques, if you implement it in any part of the oral cavity, either anterior or posterior, in a maxilla or mandible, it's always coming to the same result. This is a lower central incisor. You see the area was quite defected and the ridge was very thin. And look at the end result here. We achieved all the required success for the site. And if we look also in a different location, this is a maxillary first premolar, and you can see that the defect here, how we created the compensate the amount of bone loss in that area with this big amount of bone and soft tissue around it. And look at the final crown, it looks very healthy. So we can implement these kind of techniques in any part of the mouth. Either you are in a maxilla or in a mandible, if you are in a posterior area or anterior area, all the basics principles that I discussed at the beginning can be implemented, and you'll always create a good result at the end. I'm going to give you some important tricks when you do tension-free closure as well. This is something very important because usually when speakers talk about general items, they don't go into these details, and I will discuss with you these details. If you look at the first one, it says that when you do the releasing incision should overextend beyond the vertical incision. We saw this in the diagram that I showed earlier, that when you do a periosteal incision, it have to extend beyond the incision that we did at the vertical, also at the incisal. We also know that we have to use always a new blade whenever you do a periosteal incision. Don't use the same blade again and again. And also we have to make a releasing incision before we place the bone graft, because we don't want to have lots of bleeding and you have hematoma at the site. This will disturb the healing. And also the length of the periosteal incision should always be longer than the cristal incision. So if you make a cristal incision at the top of the ridge, when you do a periosteal incision, it has to extend more than that. And also something important, the releasing incision always extend beyond the mucogingival junction, as I mentioned in the drawing. Also, one more important thing, that when you do a lingual flap, it should be more longer than the buccal flap. So if you do, especially in the posterior mandible, when we do a flap on the buccal side, and you have to make the releasing incision on the lingual side wider than the buccal flap, because you need to compensate for the extension of this flap to make sure that you achieve good healing. And also you have to use a sharp dissection when you use a buccal for the buccal flap, but when you use the lingual flap, we should always use a blunt dissection, because we know that on the lingual side, especially in the posterior area of the mandible, we know that there is lots of vital structure that you don't want to hurt. We have the mylohyoid muscle, we have the lingual arterineural nerve also going at the side. Also, one important thing that when you do a flap, before you even graft, you have to make sure that the flap, when you close it here, it will overextend by 10 millimeter over the lingual or the palatal flap. So before I graft my side, before I put any bone graft at the side, I have to make sure that this flap can extend to the other side by 10 millimeter before I place any bone grafting. And also we have to understand that after placing the bone graft at the side, that the margin of the flap should extend at least 2 to 3 millimeter over the buccal flap. This is something very important that will give us an indication how much we released and if we released it in a proper way or no. And also one important thing that I always use the fixation sutures, which we call them the mattress suture, to allow the flap to be stable at the side and make sure that this flap is not moving with the muscle. This is something I will show you later on. I use a lot whenever I do bone grafting. Extend the mattress suture on top of the suture or a continuous lock suture at the incision line. This is something very, very important as well. So these are the kind of parameters that I discussed with you. I'm gonna show you now how to release the lingual flap. As you can see here in the picture, you can see here on the floor of the mouse, you see the mylohyoid muscle. So we do a crystal incision on the top, and then you release all the way till you reach, this is a full thickness flap till you reach the mylohyoid muscle. You can see this in the oral cavity. You will see the fibers going in that direction. And then what you do is you have to do something called a blunt dissection. I usually use the Chicron soft brush, or I can use also any kind of a blunt instrument that you have, like a periosteal elevator that doesn't have a sharp edge. And basically you just have to pull this up and release these muscle fibers. And if you look at the second picture here, you can see how this is done. So we don't do any incision, separating only the muscle from the mucosa, and this is how you release the lingual flap. And you can extend it up to 10 to 15 millimeter, and you have a good amount of lingual flap to close. If you look at this case here, look at the amount of bone defect that we have in the buccal side. I implemented the same techniques, and look at the result at the end. I'll quickly show you this video again, just to show you. This video is available on the YouTube channel. Also, you can see how it's done. So I would advise all the young guys doing this kind of technique just to see this video a few times, so it will print in your mind that this is what you have to do. So if you look here, and this case, for example, this is a case of the central incisor with a big amount of bone defect here. I have to understand that I have to augment all this area buccally, and also I have to implement the parameter that I said at the beginning. See, I put vital bone cells and mix it with the xenograft, because I need to create a volume also. And you can see the bone particles all are not scattered. It's like sticking to the side. And this is what I use all the time. And this is the bone or the sticky bone. Basically, when you mix the bone with the plasma, you can stick it at the side and see it does not move. It's stable without even kind of scattering, and you can shape it to the way you like. And then you can see here, I create this space by using the titanium mesh that you can see, and this space will prevent the soft tissue to compress on these bone cells and destroy it. And when the soft tissue is soft, I place this kind of collagen membrane on the top to protect the soft tissue from being exposed by the titanium mesh. And if we implement all the parameters that I discussed and look at the final result here, that we converted the area from concavity to a big amount of bone at the buccal side, and we compensate all the bone that was lost. Look at the soft tissue, how much soft tissue we have, and look at the bone created. And if you look at the case, before there was a big depression. Another case also that if you can see here, the same thing is implemented. I'm showing you different scenarios in different parts of the mouth because implement the same rules, you'll always achieve the same result. If you look here, we have a big amount of bone loss on the buccal side here. This ridge is quite thin because the patient had a trauma. Everything is placed, as I mentioned, you see the sticky bone sitting there, the titanium mesh to maintain the space. You don't need to use titanium mesh, you can use any membrane that have kind of support because you don't want to use a soft membrane that will collapse, because remember that we use these two parts just to create the space. If you don't create the space here, the bone will not grow at the site from here and here. And that's the main reason we use this kind of membrane. You can use any other reinforced membrane. And if you look at the case at the beginning to the end, look at the compensation. Look how much bone that was missing here, and look how you created this big amount of bone on the buccal side. And this is how the sticky bone look like. As you mix it, you can see this is just sitting on my tray before I use it. Look at the amount of height you can use, also the width, and you see it's not scattered. It's all accumulated in one piece, and you can move it around like a putty. At the same time, you can see that it's all embedded in the growth factors that coming from the plasma. So I know that this area will have a big boost of bone particles and growth factors at the site as well that would create a very good regeneration or healing. If you look here, why we have failure sometime when we bone graft, there is other things that's not only done by us as a dentist, but also things related to the patient. If the patient is a heavy smoker, a smoker interrupt the healing. If you have an infection at the site, if you have a high cholesterol, the patient with high cholesterol, this is interrupting the healing. Also, blood vessels that is always congested because of the blood pressure. Also, inflammation at the site and the vitamin D deficiency. All these things are related to the patient, is not related to the technique or the dentist. So there is different kind of bone instrument that I use to collect bone. I can either use the bone scraper here, as you can see in this picture. This is the bone scraper that you can scrub the bone at any site that you use. And look at the amount of bone that you can collect here. This is all white and bone cells. Or also, if you don't have a place or you don't have access to this, you can use the other one, which is the auto bone collector, that it has a barrel here, and you collect all these bone. You see how much vital bone that you have. I use this quite often because it's very simple and very easy. And let's see where we get this bone from. I usually get the bone from that side. The site is very safe and it's very easy to reach it. So you just make a small incision, and then you place the barrel, you cut the area here, and then you can see how the area look. It doesn't go that much deep. It's like 2 millimeter depth only. And we know that this area on the external oblique ridge, you don't have any vital structure to hurt. And the incision is done exactly the same as you do an extraction for a third molar. And you can see the diameter of the drill is exact amount to the diameter of the hole that we did in the bone. And then the barrel it become full of bone. You can take it all and use it, as you can see here at the site. So some other technique also that I use a lot now, and instead of cutting the bone and just wasting the bone in the suction by the normal drill, I move the bone at the site. I condense the bone at the site, or try to move it from a place to another, so the bone is always remaining at the site, rather than just using a normal drill and drilling it, and the assistant take the bone particles in the suction and it goes in the waste. We can use the osteodensification, which is quite a new technique that I've been using it now for nearly 5 to 6 years, and it really changed the game, as I would say. And if you look at these drills, if they go forward and forward direction, what they do, they're just cutting a normal, like any normal bear. But what if we reverse and put the case or the drill in a reverse action? If you look at the bone here, look at the bone is being compressed in a way, and you can see this compression, and you see now the bone is being compressed, especially this is when you have a soft bone, especially in the cancellous bone. So these bears is indicated only to be used in a cancellous bone, trabecular bone, and not in a compact bone. If you use it in a compact bone, it will not do the effect, because if you see here, it's always kind of accumulating the bone particles and compressing the bone to the side, as you can see, and then you can create a thick bone at that side with all the vital bone structures. This is something we have to understand when we try to graft a bone. We have to understand what kind of bone that we have. We have a type 1, which is quite a compact bone. You see type 2, it has more of a kind of cancellous bone, and the type 3 and the type 4, you have plenty amount of cancellous bone and no compact bone. This is the quite very soft bone, and these kind of bone is the indicated site for using this densification. If we use it in this type 2, you have to first penetrate through the compact bone at the area at the top, and then once you reach the area here, which is the cancellous, you can start densifying the bone. If you look here at the case of this kind of very thin ridge, and the case of a thin ridge here, that this thin ridge can be compressed. And when you compress the ridge, you don't have to remove all the bone. You see the bone here is very thin. And if I use a normal drill, it will waste all the bone. I will have nothing left. So this is the way that I compress the bone or densify it by the bears. And then you can see, you can place your implant in a vital bone surrounded all the way. And then you can do a graft on the top of that to support these thin ridge. So these are the also a technique that I use a lot now. This is the osteodensification, which is quite useful, and many people now using it around the world. And if you look at the two pictures here I acquired from my colleague, Dr. Samuel in Russia, you can see he compared the osteotomy site that he used the normal drill. You can see there is all the bone particles is gone and waste by using this normal drill. And if we use a densifying bear, look at the amount of bone particles accumulated at the site. So basically you saved all the bone particles and you didn't lose any bone by using a normal drill and taking the drill into the suction. And you can see here, this is all a site that has a fresh extraction, and all you have to do is just densify the bone rather than use a normal drill. If I use a normal drill in all these sites, I will just destroy all these interseptal bone. And if you look at the healing, we have a good healing because the implant was always embedded in a vital bone there is, and it's minimized. Also, you have to do something as well. You have to always graft the site. I always graft. I never leave the site ungrafted, especially after extraction. So this is how it looks when you densify the bone, as you can see here. And one of the important things that when you do this densification, that you have to have lots and lots of water and lots of irrigation. This irrigation is very vital, because what does it do? The irrigation will moist the bone and make the collagen in the bone softer, so you can compress it and extend it. Because remember, we are only compressing. So when you compress the bone or you densifying the bone, you have to make it very wet to make it more valuable to the kind of osteodensification. So we're gonna go now into a clinical case to see how can we implement all the discussion that we started earlier, and how to see these kind of things going into the real case at the clinic. This patient was at the clinic for restoration of the missing anterior teeth. As you can see, he had a bridge cemented on post-core, and he had all these teeth actually in a very bad situation. They were reconstructed and built and supported by a post-core, and then the patient had to do a bridge on this. When the patient came to clinic like this, we can see that all these teeth is totally destroyed. There's nothing left in the teeth, plus some of the teeth were mobile. And if we look at the occlusal view of our patient here, we see that this tooth was totally mobile, and also one here was very mobile as well here, and also there was some here as well. So we understand that we check the mobility of the teeth. If the teeth is very mobile and the teeth are repairable, cannot be repaired, we just go ahead and take them. And also, if we flap the site, we'll understand that this site has a big defect because the patient had a periodontal problem in these teeth and it was very mobile. And then after we flap the site, you can see that how much bone loss do we have because of the periodontal issue. You see here, total loss of the buccal bone, the same thing with this root. Actually, these teeth, I had to only just take them out with a tweezer because they were very mobile. Also here you see that when you do extraction, you have to be very, very careful because I want to maintain, look at the thin ridge of bone here. This ridge of bone has to be maintained because it has a vital bone cells. It will help me also to support the soft tissue. So I cannot just break it and destroy it. And if you look at this tooth here is like sitting nicely in the bone. So I want to use this here. I want to use what I have at the site because I want to minimize the trauma to the patient, and I want to also achieve a good result at the end. So if you look closely, we can see here that there's no buccal bone here, no buccal bone here. Here it has a very thin bone. As you can see, the bone here is very thin, and this tooth here is sitting nicely and covered with bone all the way around, buccally and the mesial and distal. So I want to maintain this tooth here because I don't want to take it out. I don't want to destroy more of the ridge. So what I'm gonna do, I have to show you later what I'm going to do with this tooth. This is actually a picture that I took with my camera to show you the type of bone particles that I use. When I use this kind of bone particles, these bone particles are not the smallest size. What I use these particles for, because you can see, we mentioned before that the bone cells need to grow between these particles. If I use a very small particles and I compact them like sand, they will have no kind of holes in them. So I need these spaces for the bone cells to go inside these spaces. And also I need these spaces for the vascularization. If these bone particles are very compact to each other and there is no place for the blood vessel to penetrate, we will not have blood vessels growing at the site, and you will not have blood. And this is one of the particles, one of the items that I said at the beginning, that you should allow always the blood to grow at the site. So if you compact this bone very precisely and you have no space, the blood will not grow and you will end up losing your graft. So we come back to the site here. I see that I have no wall on that side, so I have to build my own wall because I cannot just put bone graft and just leave it like this because the soft tissue will compress. So I have to support, I have to build my own bone. Here, if you can see, this bony ridge will act for me as a barrier for the soft tissue to invade. And you can see here, I have a big deficiency here, a big dehiscence, and this root here I'm going to leave it because I want to submerge it, because if I take this root out, this bone will dissolve by time because this is a bundle bone that's very thin. It doesn't have blood supply enough to maintain it, and it will resorb and we're going to have a defect. So my target is to submerge this root, and you can see here I cut the root all the way under the bone level, and make sure that it's totally under the bone level and it's not above the bone level, and then you leave it there and the bone will cover the area and the soft tissue, and this will act as a support for the site. If you look at the occlusal view, you can see here we created this wall so the bone can grow here uninterrupted, and then also we have here this small ridge here, and we will compare what happened at the end between these two sides. We left the root to support the bone, and also we left this ridge to support the bone at that site. And here we didn't have anything, so we placed our titanium mesh at the site. So we move with the case and see what happened here. I graft the site with sticky bone, as I mentioned, which is I have to use an osteoinductive material because I need the bone to grow at the site. I use bone from the retromolar area of the patient, and I mix it with a xenograft just to make it consistent like a butty. And then also everything is mixed together with the plasma because the plasma will give us lots of growth factors that will initiate the healing and make the healing go faster. So we fill these gaps all with the bone, as you can see this. And then you can see the sticky bone, how it's very stable and it's not moving. So this is something important for the stabilization of the graft. And then if you come back to the graft, you see here that I placed a collagen membrane here as a first layer, and because I want to protect the titanium mesh. And then also I placed the PRF membrane that you can see here and here. The same thing this side as well. Collagen membrane is used, and above that is the PRF membrane is used on the top, because I want to make sure that this area is totally protected and I don't want to have any exposure of the site. So we suture the area, as I mentioned here. You can see my incision flap all the way to the distal here, and I want to have a broad base here for the base of the flap. And then you can see that I use the stabilizing horizontal mattress so the muscle does not pull the flap. And this is done before I do the interrupted suture that comes at the bottom here, as you can see. And something very important also that you have to know, when you suture like this, you don't have to make sure that the knot is very, very tight, because I see in many colleagues doing this. I usually like to leave a space, not make the suture very tight, because we understand that this area will have a bit of a swelling, and I don't want the swelling to leads to a tie suture and then snap the soft tissue and cut it. So this is something very important. Make sure that there is some looseness in the sutures, not totally tight, because if the tissue swells, it will not cut the soft tissue by the suture. If we come back to the site after 5 months, we see how much bone that we created here, and you can see that amount of bone is become very vital and is bleeding. So I know that I have a healthy bleeding bone, and the bone have lots of vital bone cells, and you cannot see any kind of white particles, because I like to make the ratio higher of vital bone cells to xenograft particles or allograft particles. If you look here now to the site, we wanted to evaluate what we reach. You see the site, when we rely on the root submersion technique and the thin bony ridge, we did get a bone, and it's a quite big amount of bone. But look at the other side here. Look at the thickness of the bone in this side. This bone has a bigger amount of size, because we created a bigger chamber by using the titanium mesh on the buccal side. And because we have this big gap, we created a good space for the bone particles to grow all the way from the palatal all the way to the buccal, and that's why I created a higher space. So if you look here, we didn't leave that much gap for the bone cells, because we relied on the submerged root and also on the bony bridge, which is here. And then if you compare to each side, you can see that if you leave more space for the bone cells, you will have more bone to grow at the site. This is something very important. If you look here at the site, we can see that the root submerged in a nice way. It's under the bone level, and it will allow soft tissue to cover it totally. And then also, if you look here, we can understand that whenever you create more space, you will have enough amount of bone. But for the time being, this bone is enough for us to start our implant procedures. If you look buccally as well, you see everything is totally healed and everything is covered. And the nice thing about this thing, that you can see that all the bone is vital bone. There is no white particles. You can see that it's totally healthy bone that is vital, and it's all grown at the side by our GBR technique. Now we have to densify, because it took me a few months to grow this bone. I don't want to drill it and just waste it in the suction. So I densify the area here, because I know this is a soft bone that is just made by us. So I densify the two osteotomy site, and the treatment plan that we wanted to place one implant at the lateral, the other implant at the other lateral, and then we do a 4-unit bridge. Remember, you can see here the submerged root is still there. And then if you look closely, we see that we placed the implant in a very nice position, because I want to aim for a screw retained kind of restoration. And this screw restoration has to be, the screw has to be coming to the palatal side. Usually I place like a template or a stuck down tray that my lab does for me, to see where the location of the screw coming. So this screw and this screw should come more to the palatal side, because I'm aiming to have a screw retained. You see, because we have enough amount of bone, I can align the implant in the way that when I put the implant, the final screw will be pointing toward the palatal side. So after the implant is placed, and we come back to the healing here, and you can see that we have a good amount of healing. But what I see here, I didn't like these depressions here and depression here. And this is because we have deficiency in the soft tissue. We've flat the site many times. So what I need to do now, I have to compensate this and this here, and I have to increase the thickness of soft tissue. We understand from studies that you need thicker soft tissue around the implant. The thicker, the better, because we need a big amount of keratinized seal around the implant. If we have only thin tissue that will lead to bad seal, and will have a bacterial invasion at the site, and we might lose the implant if we have any kind of infection. So what we do in this case, we come to the palatal site to make a small incision, which is half thickness incision, and then you create a releasing incision vertically left and right to the implant, and basically you do like a half thickness dissection and move all this soft tissue from the palatal to the buccal here, as you can see here and here. And you can see the area in the middle here doesn't have keratinized tissue, but in the same time it's covered by non-keratinized tissue. And now we have the plasma as well. This plasma as well here, as you can see that, the soft tissue, as you can see here, will start growing to connect to each other. What happens usually, something that we all have to understand, that when you have a wound, and this wound is kind of have two kind of layers of the same tissue, they will grow and reach each other, which is here, this soft tissue here and this soft tissue here, they will grow toward each other to seal the site. So even this is exposed, and this is also exposed at the back, we should leave it and it will heal by itself. And just after 2 to 3 weeks, you can remove the sutures, and look at the amount of soft tissue that we created here. Look at the amount of buccal thickness that we have on that side and also on that side. And we understand, if you look at the case before we do the graft and after, look at the difference. We created a bulge. At the beginning, we had a concavity here and concavity here. Look at the amount of soft tissue created on the buccal side. And this only in 2 weeks. And it didn't have to go to another site to graft and take a free gingival graft and graft it the site. All you have to do, just move the tissue from the area that have a big amount of tissue to an area that you want to increase the tissue thickness. So I don't have to have many sites of surgery. And then when the site is ready like this, now I can take my impression. You see, I used in this technique a closed tray impression, because I know my 2 implants are parallel to each other. So the impression caps can come out easily. There is no angle at the site that it will detach these impression caps. And then when the impression is taken, I check also the stability of our implant. Look at the ISQ, which is the stability. It's 47 ISQ, which is a very high. And I know that this implant is ready for loading. So this implant is placed in a grafted site, not a site that was already there. So we grafted the site with the implant, and we placed our implant in a totally grafted bone. And look at the stability. It's a 74 ISQ, which is quite good and quite high. So we know that we can load our bridge on the implant. So the bridge is done, screw retained, as I mentioned. You see that I placed my screw holes to the palatal side, because this is planned from the beginning. You see the holes here. And in this kind of case, what I usually do, I do an incision on the palatal side, here and here. And you can scrub the tissue a little bit to make it slightly bleed. And then you place your implant untight. And that's why you can see the blood here, because this is what I do. I do little incision. I don't reach the periosteum on the palatal side, just to expand the socket. So when I push my crown, the crown will be pushed inside and create a nice emerging profile at the site. And then this is after sealing the screw holes. You see everything is sealed. You don't see anything, and I don't have any kind of cementation at the site. So I know everything looks very good and healing. If you look here at the case and how we started the case before and after, look how much soft tissue we have buccal to the implant. A big amount of soft tissue buccally. So I know this implant is sealed nicely. They will have no bacterial invasion, and we have enough amount of bone supporting the implant. So I know the implant, after loading, it will have adequate amount of support to the bone. And this is how we start the case. This is how we, just the day of insertion of the bridge. Sadly, this guy is actually doesn't live in Dubai. He lives in China, and he used to come from China to have this treatment. So it's a bit of a challenge to do this. But you see our lab technician is a very talented guy, and you can see that he's very nice. His name is Kivork. See, he did all these characteristics in the crowns to mimic the natural teeth that the patient have. And if you look at the final case here, look at the smile looks normal. The teeth has a good position, and everything looks nice and healthy. The patient was very pleased that this is all done in less than 6 months. So from start to end, we did everything, and everything looks really good. And we didn't take a long time to finish this case. And this is because we implemented all these rules and this. I'm going to take you to another case as well now. Just it's showing in a kind of a video. It's a different scenario, but just implementing the same techniques. And we'll show you also what we do in any case, as long as you follow the principle that I discussed with you at the beginning, you always have a predictable and you always have a good result. So I will leave you with this video to watch, and then we'll see how we proceed. This impacted tooth was removed. See, it's very close to the. And then we started having this kind of exposure. The root is totally exposed. I have to address this because I won't have a good papilla between the implant and the tooth, and there is no enough bone, so I use the tenting screws. You can see the big bone particles, also sticky bone. You see how I cover the bone on the exposed root, because I want to create a papilla at the site. Everything is covered with the membrane because we have already tenting screws, suture everything with the two technique of sutures. And then if you look before and after how much we create the soft tissue, you can see the tenting screw here in the x-ray. See, we created the papilla next to the premolar, and then you can shape the gum the way you want. This is the time of the insertion of the crown. Look at the nice papilla that we created, even though there was big exposure of the root of the second premolar. Look at the keratinized tissue sitting around the crown. We know this crown is going to be there for a long time. And I would like to thank you very much for your attention. You are very welcome to join our group here. This is a group we have on the Facebook. You can share your cases. You can ask questions. And it's not only a group for kind of surgical and implant group. It's a group for everything. So you can talk to your colleagues about fillings, root canal, whatever you want to discuss. And this is my Instagram. If you want to follow to see cases, all the cases that I do, I usually post them on the Instagram so you can see them. You'll see also lots of videos on the YouTube as well. So you're welcome to join and also to see all the cases as I mentioned in this Instagram or the YouTube channel if you'd like. Thank you very much.
Thank you, Dr. Rashed, for the lovely presentation and for your fantastic clinical cases. It was definitely a pleasure to have you as an esteemed speaker during the live webinar. Friends, we take about a short 2-minute break. And in the short 2-minute break, I request you to kindly note down your questions in the question and answer section so that we can discuss them one by one. Dr. Rashed, I request you to kindly stop your screen share for a moment.
Okay, thank you.
Friends, we hope you have been noting down your questions. Friends, very quickly, a little about DentistChannel.Online. We DentistChannel.Online, we are a media company. And as you know, we complete close to 24th. This is the 24th live webinar. This has been all possible because of all you lovely people for your constant support and for being very active and being very enthusiastic about the dental live webinars. We request you to kindly share and comment on our YouTube page. Please do subscribe to our YouTube page. Please do be in touch with us so that we can help you to stay in touch with regards to anything that's happening from the world of dentistry. Please do stay in touch. This is Dentist Channel Online's official website, wherein we have an array of blogs, we have an array of scientific presentations, articles, and everything that would excite you from the wonderful dental fraternity. I request you to kindly also keep supporting us by going through our website. Here's our social media profiles. I request you to kindly subscribe once again. An e-certificate of participation would be only given to you upon your request. I repeat, an e-certificate of participation would be only given to you upon your request. So for that, you need to WhatsApp on the below mentioned WhatsApp number, which is there on your screen. I repeat, an e-certificate of participation would be only given to you upon your request. Please mention your full name and the name of the webinar. Friends, this is about the next webinar. The next webinar would be taking place tomorrow on the topic cemented versus screw retained restorations. You can find the link to this to the webinar in the chat box. I request you to kindly register for tomorrow's webinar. Thank you very much for your time. Dr. Rashed, can I have you back?
Yes. You can read the questions?
Yes, sir. Just a minute. All right, sir, we are starting on with the live question and answer session. Starting with the first question, can titanium mesh be used?
When or I didn't hear the question again. Can you say again? Can or when?
No, it says can titanium mesh be used?
Yeah, any titanium mesh can be used if you need to create a space. I use it a lot actually, the titanium mesh. So any defect that you can use the titanium mesh, it doesn't matter where you can use it, and you just have to follow the guidelines to make sure that the titanium mesh is not exposed.
Thank you very much, sir. Moving on to the next question. Can you please tell me about the biological principles and therapeutic application of GBR?
The biological principles?
Yes, and the therapeutic applications of GBR.
Okay, the GBR I mentioned at the beginning, this is used whenever you have a defect of the site. If you don't have enough bone to place your implant, or if you have a defect and you want to increase the thickness of the bone, height or thickness, if you do like a sinus, for example, you want to elevate so you can graft the site also. You can do a sinus elevation. You can place the bone graft to the side to increase the vertical dimension. You can also use the graft in a horizontal direction if you have a thin ridge and you want to increase the thickness of the ridge. So it's every indication that you want to increase amount of bone, you can use it. And the physiological, you said physiological indication. I think it's just like if you use any kind of a healing process, you create, you initiate at the site some sort of physiological inflammation. Inflammation leads to healing, and then this healing will create the blood to circulate more at the site. You will have lots of growth factors at the site. You will have also stem cells at the site will be differentiated into osteoblast and start producing the bone at the site.
Thank you very much, sir. Moving on to the next question. What are bioabsorbable scaffolds for guided bone regeneration?
What the resorbable scaffold? I use usually is xenograft, or I can use cortical cancellous allograft. It doesn't matter. You can use this or the other one. Whatever you have as just a supporting structure, you can use it. You can also use the hydroxyapatite or tricalcium phosphate. It doesn't matter. You can just use it only as a material to hold the particles together and to allow the bone cells to grow around it. Usually, if you use cortical cancellous allograft, it sort of mature nicely with the bone. If you use more of a xenograft, it will still have remnants there, because we understand that this xenograft particles is not totally absorbable. The same thing with also the hydroxyapatite. If you use them, they can also merge and start getting infused with the matrix of the bone as well. So you can use any one of these things, either xenograft or alloplast, or you can use also alloderm.
Thank you very much, sir. Moving on to the next question. Are barrier membranes absolute necessary for all bone grafts? In which situations can a barrier membrane be avoided?
Okay, if we use this sticky bone that we mix it with the plasma, the PRF, this mesh is very strong, and it does not let the bone cells to be invaded by the soft tissue. So you can avoid this membrane. Also, you can avoid membrane if you have also PRF, like the membrane, the PRF membrane, that you can use it also as a membrane above the bone substitute as well. Also, if you have a amount of thick periosteal flap, you can just use it as a membrane for the site. But the problem, if you don't use a barrier membrane, sometimes when you come back to the site and you open the site and a flap, you will see all the bone particles is sticking to the flap walls. So this is something that you have to keep in mind, that if you want to come back to the site and you didn't use the membrane, you'll have lots of bone particles embedded at the flap. And sometimes if you want to resuture it again, it's kind of interrupting the suturing technique. That's why if you think that you will do like a second stage and you want to re-expose, it's better to use a kind of membrane to protect the bone graft from being adherent and sticking to the membrane that you didn't use. And then what will happen, that the soft tissue will stick to these particles. So this is the only indication that you, if you don't need to come back to the site, if you just place your implant and graft and suture it, with even you mix it with the plasma, you don't need to use a membrane at that time.
Thank you very much, sir. Moving on to the next question. The buccal flap should be 10 millimeter longer than lingual. How will this be possible with thin gingival biotype?
Okay, this is possible only if you do the releasing. The thin or thick biotype has nothing to do with the flap extension. The thin and thick biotype is the thickness of the flap at the time of doing the surgery. The thickness mean from the bone to the external surface. But when you stretch the flap by doing a releasing incision and you use the vertical incision, as I mentioned, with a broad base of the flap, and you extend your periosteal incision wider than the incisal incision, you can end up having a lot of tissue mobile, because basically When you release the flap, you make the flap mobile. It doesn't matter if this flap or thick or thin, because the thickness is the service from the bone to the external area. If the flap thin or thick, it doesn't matter. As long as you do the incision in a way to release it and it's not sticking to the underlying periosteum, you can extend it as much as you like. It's nothing to do with the thick and thin soft tissue.
Thank you very much, sir. Moving on to the next question. Question from Dr. Roy. Good afternoon, sir. Thank you for the lovely presentation. Your cases were fantastic. If the process of harvesting the bone graft from either symphysis menti or tuberosity and the process of grafting it in the needed site can't be done on a single appointment due to any medical reasons, what will be the best medium to store the graft?
If we can go to that site, if we can take bone from the patient, you mean?
It says that and the process of grafting it in its needed site can't be done on a single appointment.
Yes, it can be done single appointment, yeah. This is all done together in one visit, in the same visit.
Thank you, sir. Moving to the next.
You can graft the site and take the bone from the retromolar area in the same visit. It doesn't have to be in two separate visits. You can do it all in one time.
All right, sir. Moving to the next question. Do we need to make any changes on the bone in the operative site before grafting?
No, you don't need to do anything. Just make sure that the bone is totally exposed. So you don't have to have any granulation tissue or soft tissue lying on the bone, because you need vital bone to be attached with another bone particle that you placed. And you see in the first case that I put on the presentation, I make decortication because I need to make sure there's lots of blood supply coming to the site. As I mentioned in the 4S, the supply of blood is very crucial. So when I place a graft at the posterior mandible, I have to make sure that the site is bleeding, and I do perforation. I see many people say that you don't need to do this, but I don't want to take the risk. It doesn't harm me to do this perforation. You can just do the perforation at the site, make sure there's bleeding coming to the surface, because when the blood comes to the surface, it will bring the nutrition to the site, also will bring the stem cells to the site, will bring a growth factor to the site, so it will help. It will not harm anything. It's better to always do this. This is the only thing you should do, just perforate if you're coming to an area when there is no blood. You always have to look at the site when you place the graft. If there is no blood at the site, so you have to think, where can I get the blood to the site? You either decorticate, or you have to make sure that the flap is totally covered with the periosteum, because the periosteum have lots of blood supply at the site.
Thank you for answering to the question, sir. Moving on to the next question. What xenograft material do you prefer?
What xenograft material or brand?
Yeah, xenograft material, sir.
Well, I think the question is
yes, the question is brand. Yeah, the question may be brand. What xenograft brand do you prefer?
Well, believe it or not, I really don't know. I ask usually my assistant to buy the. I just tell her xenograft. I don't care what brand, because I care only about the structure, what material I'm using. If I use a xenograft, it doesn't matter the xenograft to which brand, because at the end they will do the same job. So no matter what brand, because the brand doesn't really have an impact on the result. It's I know that many companies sell brands on expensive kind of prices, and they claim they are better, but I don't see any scientific proof that if you buy an expensive or a cheaper brand, there's a different effect. Because at the end of the day, if you use a xenograft, I use it as a xenograft because I know this has an animal origin, and the use of this graft only to act as a scaffold. So if the brand is famous brand or non-famous brand, I use actually many brands in the clinic. I use brands from Korea, brand from America, brand from Germany, brand from I can remember, I think some brands also from East Europe. It doesn't matter, because at the end of the day, Xenograft only act as a scaffold, and it will only support the cells. It doesn't have any other action. It's like having it's having like a scaffold for someone to climb a building. So whatever scaffold you put, you can put wooden scaffold, you can put metal scaffold, you can use any scaffold that you want, but the target is to climb. So these cells can climb on any kind of xenograft. It doesn't matter what brand, or it's made in any country or made in by any brand.
Thank you, sir. Moving to the next question. What suture material do you use for closure after GBR?
Yeah, I usually I used to use 4-0. Now I use more 6 and 7-0, especially if I want to make sure that there's no any scarring at the time. Usually, and I always use also the PTFE suture because they have kind of elasticity. So if the area have an expansion, they can expand. And I always use also nylon and the monofilament. I never use silk because the silk accumulate bacteria, and the monofilament as well does not accumulate any food particles or bacteria. So this is my first choice all the time.
Thank you, sir. Next question from Dr. Nazima Harris. How do you manage if you have a membrane exposure?
How you manage membrane exposure?
Yes, sir.
Well, I'd like to know which membrane. If it's a normal membrane like a collagen membrane, you can just leave it because it will just the skin will cover it. If you have, just make sure that the area is clean, and it's not a problem. If you have exposure, it's not a big deal. You can just leave it, and the tissue will absorb this membrane, and the site will cover. The only thing that you have to be careful when you have this kind of exposure, to make sure that the patient is cleaning very good. You give the patient lots of irrigations and like rinse, mouth rinse, to use like chlorhexidine irrigation, and also mouthwash. And even if the patient have an exposure and just keep the site clean, it always helps. One more thing also you can do like a suck down tray to the area to make sure it's covered so it doesn't have communication with the oral cavity, and you get the patient to wear it for some time just to make sure that it does not leave the area exposed. But you have to make sure that you have to explain to your lab to create for you space, because you don't want pressure at the site. So you can use a suck down tray that's supported on the teeth surrounding the site of the graft. I don't have it here with me now, this picture, but usually if I see a patient who's a smoker or a patient who's like not having good oral hygiene, this is what I do. I create a suck down tray that covers the site all the way buccally and lingually, and it's usually the patient wear it like a bleaching tray or a suck down tray, and they make sure that this have a space so it doesn't compress the tissue, and it allows the tissue expand for the swelling after healing. During the healing, I mean, it doesn't compress the site.
Thank you, sir. Next question. Can other barriers also be used to contain the bone graft except titanium barriers?
Can you say again, please?
Sure.
And the what?
Sure. Can other barriers also be used to contain the bone graft except titanium barriers?
Yeah, I mentioned, you see, the first few pictures were like different techniques. What I'm saying to you that you need something to stop the soft tissue crushing the bone particles. So you can use anything. You see the case that my colleague used in the States, he used the Curi technique, which is a bone like a shield that doesn't allow the tissue to invade. You can use a reinforced PTFE membrane as the first case by Dr. Peter. And so it's anything that allow the space to be there. Any material that allow the space to be there, you can use it. I didn't say that you have to use only this. At the beginning, I said that you have to have a space maintenance. And the space maintenance can be created either by tenting a screw. You can use a block like Khoury technique. You can use a reinforced membrane, a PTFE membrane. You can use any material that allow the space. Tenting screws I use sometimes, well, like last video that I show you. So anything that creates space and prevent the soft tissue collapsing towards the graft site, this can be used. It doesn't matter what you use, but anything that you use that will not let the tissue compress the site, you can use it. The only thing that I don't like to use, that when the people use this soft collagen membrane that you wet them and they collapse at the site, this will not act as a barrier because they cannot hold the space. They cannot maintain the space. They just, once you make them wet, they compress and collapse to the defect and they don't hold any space.
Thank you, sir. A few more questions. What are your guidelines for long-term implant tissue stability?
What's the guideline for implant long-term stability?
Yes, sir, that's the question.
Yeah. Okay, this question is actually, you should do this at the beginning. When you place your implant, make sure that you have enough bone buccally to the implant, which is 2 millimeter or more of bone. Also, make sure that you have a keratinized soft tissue vertically and horizontally to the implant. I usually like to have like 2 to 3 millimeter on a buccal direction horizontally, and also for vertical should at least have 3 millimeter, because also implant will have biological weights, and we should create enough height of soft tissue to allow for the implant to be completely sealed by a keratinized tissue. If you have a thin tissue at the end of the implant treatment, you can start doing a connective tissue graft to thicken the tissue, because when the tissue is too thin, it will always resorb, and we don't want to have this. This is something that we have to consider at the beginning. You have to expand the tissue in a way that you have thick tissue, and also you have height at the tissue that it will give you a seal for a long term. If you have a thin tissue to start with, I'm sure that it's a matter of time after function, you will have bone resorption, and the bone resorption will have also a tissue recession. And that's why the tissue and the bone go together. If there is enough bone, it will support the tissue. And if there is enough tissue, it will support the bone. I'm talking about the soft tissue. So if you have a thin gingiva and you make a big amount of bone, this bone will not be protected by a thin gingiva, so it will resorb. And the vice versa as well. If you have a thick bone and a thick gingiva and a very thin bone, it will also resorb. So you need a thickness in the bone and also thickness in the soft tissue if you're looking for a long-term success.
Thank you, sir. Next question is, do you offer any hands-on courses in UAE? Can we join your hands-on courses to know more?
Actually, the hands-on courses we sometimes do this year, but this is not on the live patients because the rules doesn't allow. You know, I am also working with my partner, Dr. Darcy. We have a training center in Portugal. We do lots of live surgery. You can see the surgery because we have the setup for this. And it's also under the clinic name. It's called B Clinic Training, BE Clinic and Training. And you can see, I think on the Facebook, we usually have lots of courses for extraction, for socket shield, for episectomy, all the surgical work, soft tissue grafts like this. So anyone would like to look at this at the Facebook and they will see the courses, you're welcome to attend them. If anyone coming to Dubai, they're welcome to visit the clinic. And if we have any live surgery, they can watch it and they see it's not a problem.
Thank you, doctor. Friends, you can get in touch with Dr. Ehab Rashed. You can follow him on his social profiles to know more about the courses and the upcoming courses. Thank you very much, sir. Moving on to the next question. Question from Dr. Deepa. Do nerves regenerate correctly after bone graft? Is there a risk of traumatic neuralgia if the regeneration runs amok?
Sorry, can you read it again?
Sure, sir. Do nerves regenerate correctly after bone graft? Is there a risk of traumatic neuralgia if the regeneration runs amok?
You mean if you do bone graft, if you have neuralgia? Well, first you have to know where you're doing your, I mean, the bone graft does not cause neuralgia. It's as long as you don't touch the nerve. You can only get this if you injure the nerve. So if you're releasing the flap from the buccal side, for example, you have to be careful with the mental nerve. Also, if you do a graft on the posterior mandible, for example, you have to make sure that if you use a fixation screws, or if you're using tending screws, make sure that when you screw the screws into the bone, that you are not like invading the space for the nerve. This is the only way you get neuralgia. But if you using just a normal kind of GBR and you're not touching the nerve, there were no reason for neuralgia to happen, because this is only happening if you do an injury to the nerve, and the bone graft does not give any neuralgia to the nerve.
Thank you very much, sir. Last two questions. By using titanium mesh and sticky bone graft, can we get vertical augmentation, and how much?
Of course, you can get vertical augmentation, and you can get vertical or horizontal. The thing is, you see, we discussing before the four principles of GBR. If you create a space horizontally or vertically, the bone will grow. How much? It depends on the site, because you cannot just think that the bone graft will just grow in the air. You should have a site that's supported by enough blood supply and enough vital cells to come to the site. So how much? It depends on the amount of the surrounding area. If you have a big borders to the site, if you have nice big subbone to the site, mesial and distal, this will create a blood supply to the site. It will create also a source of cells to the site. So the word how much, it depends on how the site have enough blood supply, how the site can have enough vital cells, and based on that you can increase your bone graft. And if you think that the bone graft is not enough, you can re-augment it again. There is you see, there is the principles of bone growth is the 4 points that I said. If you have a space and you allow the space to be totally supplied with blood, and the space have enough vital cells, and the space is totally covered at the end of the treatment, you can have a vertical horizontal growth. It's very simple. Usually people go into the trauma department. They have a big fracture after car accident or whatever, motorbike accident, whatever. The bone is totally crushed. They go to the hospital with a big amount of bone, maybe sometimes 10 millimeter, 15 millimeter, 20 millimeter of fracture. And within few months, the bone heals. And the reason this happened because you create the same concept. You create a space and you let the blood flow, and then you also have the vital cells at the site, and you protect the site from the soft tissue. And eventually the bone will grow, because the bone will need these parameters to grow. Okay?
Thank you very much to answering to the question, sir. Last question from the live question and answer session. Does the titanium meshwork resorb itself, or do we have to remove it in the future appointments?
No, of course we have to remove it, because it doesn't resorb. It's a metal, so it does not resorb. It's better to remove it after the healing, because it's a kind of irritation to the site as well. And especially sometimes if you leave it for a long period of time, it can cause exposure. So usually we keep it for the healing time, which is about 4 to 6 months, and then you can remove it. And one important thing, when I used titanium mesh, I used a lot of vital cells, because what happened if the mesh is exposed? The body recognizes the cells. So the soft tissue biologically understand that the soft tissue should cover the bone. Like if you're having an extraction site, you pull a tooth out and the bone is exposed, you come back after 2 to 3 weeks, you will see that the soft tissue is already covering the bone, because this is the natural biology of the body. So when you have at the site lots of autogenous bone from the patient, and the soft tissue at the site recognize these tissue, there's like a code between the cells and the tissue. They know that these cells are bone cells, so the body has to grow skin or soft tissue above it. And that's why if you have a titanium mesh that I use, I put lots of vital cells to let the other soft tissue recognize that these cells is the body cells and it has to be covered by the soft tissue. This is one of the reasons that when you use a titanium mesh, you should put lots of vital bone cells, not just pack it with many bone substitute like xenograft, because if the mesh is exposed, the gum will think that this xenograft or this bovine bone is a foreign body, and it will not cover it. And this is the reason that people use only xenograft have more failure if the area is exposed. If you expose the area and it's full of just the xenograft, you will lose everything, because the body will act towards this xenograft as a foreign particles, because it's a non-vital and it's not even of a human origin. So it will eventually be rejected and it will be capsulated and it will come off. And that's why whenever you use a xenograft, it's better to mix it with autogenous bone cells, so the body can understand the code of the bone cells to the soft tissue and can create a coverage above it.
Thank you, sir. That brings us to an end of the lovely webinar. Once again, on behalf of Team DentistChannel.Online, I'd like to thank you, Dr. Ehab, for the fantastic and the lovely presentation that you gave us during the course of the live webinar. I'd also like to thank all our participants for attending this live webinar and for being so patient and for being so interested and with the lovely questions that you've asked. Please do get in touch with Dr. Ehab for any of your doubts. Please do follow him on his social profiles. Also, please do subscribe to our channel so that you can get notifications on the latest updates and on the upcoming webinars. Thank you very much all. May you all have a good day.
Thank you. Thank you very much.